Hello, I'm Seiichiro Abe, Endoscopy Division, National Cancer Center Hospital, Tokyo, Japan. I'm an associate editor in gastrointestinal endoscopy. Thank you so much for giving me the opportunity of the author's interview. I'd like to introduce my top tips article entitled Magnifying Endoscopy in the Esophagus and the Stomach, which has been recently published in Gastrointestinal Endoscopy. Virtual chromoscopy has been used for the diagnosis of upper GI neoplasm. Specifically, magnifying virtual chromoscopy using narrowband imaging and blue light imaging has been reported to be useful for lesion characterization and margin delineation of gastrointestinal neoplasm. Detailed preoperative endoscopic evaluation is essential to achieve R0 resection and curative endoscopic resection with ESD. This issue demonstrated tips and tricks of magnifying endoscopy for superficial esophageal squamous cell carcinoma and early gastric cancer. First, general tips for magnifying virtual chromoscopy. Magnifying endoscopy with narrowband imaging or blue laser imaging should be performed after cleaning the surface of the esophagus and the stomach with water with thymechicone. The combined use of deforming substance of thymechicone and a mucolytic agent such as Pronase is highly recommended to remove the bubble and mucus and obtain high-quality endoscopic images. Since Pronase is not available worldwide, an alternative is N-acetylcysteine. The careful cleaning of the target lesion is important to avoid bleeding. Using a syringe and gently irrigating against the lesion is better than vigorously directing the water jet against the lesion. Before magnifying endoscopy, we should perform the non-magnifying endoscopy using high-definition white endoscopy and virtual chromoscopy to evaluate the gross appearance of the target lesion. Diagnostic endoscopy should include the identification of an area of interest, such as a nodule, depression, or an area with remarkable redness. A soft black cap is necessary for the optimal field of view and avoiding scope contact with the lesion surface during magnifying endoscopic examination in the esophagus and the stomach. In terms of magnifying endoscopy for esophageal cancer, a magnified virtual chromoscopy helps characterize an esophageal lesion, allowing for detailed inspection of the microvessel pattern. Particularly, the evaluation of interpapillary capillary loop, IPCL, proposed by Professor Haruhiro Inoue, allows us to predict the depth of invasion of esophageal squamous cell carcinoma. Magnified virtual chromoscopy also allows a detailed inspection of the microsurface and microvessel pattern of the columnar epithelium in the buried esophagus, facilitating the diagnosis of high-grade dysplasia and adenocarcinoma of the esophagus. During the magnifying endoscopy in the esophagus, one of the top tips is air deflation to obtain the stable scope position. Performing magnifying endoscopy with standard air inflation in the esophagus is challenging because the esophagus is anatomically a straight tube and access the endoscope is likely tangential. The endoscopic tip with the soft cap is gently applied towards the lesion using an up angle and air suction in the esophagus lumens. The scope should not be pushed hard. This technique provides an in-face view of the esophageal neoplasm. Magnifying endoscopy should be initiated with low power magnification, and endoscope should be carefully and slowly pushed forward. Starting the procedure from the oral side of the background mucosa to focus on the target lesion is very important. This technique facilitates the focus hypermagnification while avoiding bleeding. Next top tips is magnifying endoscopy for gastric cancer. What can be observed by magnifying endoscopy in the stomach? Magnifying virtual endoscopy allows a detailed evaluation of microsurface and microvascular pattern on the gastric mucosa. It also facilitates a visualization of the demarcation line between the cancerous and non-cancerous background gastric mucosa. The simple magnifying endoscopy diagnostic algorithm for early gastric cancer, MESTA-G, which is proposed by 3 Japanese associations, defines the criteria for early gastric cancer diagnosis as an irregular microvascular pattern or irregular microsurface pattern with a demarcation line. It facilitates accurate differential diagnosis between non-cancerous and cancerous lesions. It also enables the correct diagnosis of lateral extension and appropriate treatment decision making for early gastric cancer. After identifying the target lesion, similar in the esophagus, the magnifying endoscopy should be introduced at a low power magnification level, which facilitates focus on the background gastric mucosa, evaluating the presence or absence of the demarcation line. Some early gastric cancers showed only mild structural atypia or present with non-neoplastic surface structures, which are difficult to distinguish from inflammatory change in the gastritis, especially a patient status post H. pylori eradication. Therefore, assessing the non-cancerous background gastric mucosa surrounding the lesion is essential to correctly determine the lateral extension of early gastric cancer. And it is important to identify the slight irregularity of the microvessel and the microsurface of the lesion. A more detailed observation is performed to evaluate the microvessel and microsurface pattern at a high power magnification if you have an endoscope with a dual focus function, and full zoom magnification is more preferred if its function is available. During the procedure, the saline immersion endoscopy helps improve the quality of image, eliminates light reflection, and enables acquisition of an end-phase view of gastric neoplasm. After air and fluid containing the Seiichiro are completely removed, the saline solution should be gently immersed in a water jet or syringe. The tip of endoscope is directed perpendicular to the lesion. A black soft cap is essential to stabilize the scope tips and maintain an optimal distance during the magnifying endoscopy. During the procedure, the caution not to push the endoscope hard against the lesion should be exercised. Air diffraction followed by intermittent gentle water immersion from the tip of the endoscope filled with saline within the cap allows for the tip of the endoscope with the soft cap to float upward to a lumen during magnifying endoscopy. This technique can help maintain an optimal distance to the target lesion and bring it to the focus. A magnifying endoscopy also helps predict the histological type of early gastric cancer, differentiated type early gastric cancer, or undifferentiated type early gastric cancer. However, it may not always be accurate even with magnifying endoscopy. A targeted biopsy should be obtained from the lesion, and histological type should be comprehensively evaluated based on the endoscopic and histopathological finding. The treatment decision should be made after detailed evaluation according to the guideline. Peripheral biopsy from outside the lesion are an option to determine the lateral tumor extension in case with endoscopically indeterminate boundaries, because some early gastric cancer contain non-neoplastic area on the tumor surface, especially in undifferentiated early gastric cancer limited to lamina propria mucosa and early gastric cancer after H. pylori eradication. I hope this article will help you introduce and improve your skill of magnifying endoscopy. Thank you so much.